This is only gonna be. Oh, okay, we're in the. We
So how are you going to let her see this though?
I think we're gonna need to log in the desktop.
Hello, we are just trying to figure out how to make this work for you.
No problem. Thank you so much.
So if we just go to
Thanks. Bottom right, Joey says. There you go.
oh, there we go. What's
Why don't you
different on
stand
every
up?
screen?
Yeah, you get it. You're already nervous.
Something went wrong.
Oh, no, maybe I know the different account that I tried.
Okay. Oh God, I have to know my Microsoft.
The senior tech support and you're.
But I'm literally a 3.
I can't type because this is not plugged in because this is.
This is so, all right, this is higher level thing.
We
These
could,
are
I
my-
could just turn it and she could see the screen and then she could
That's
hear me
perfect.
talking.
Let's do that.
Okay. So.
That's much easier, I think.
Oops, that's not what I want. So let's get it.
And sit that way.
Okay. All right. So we're going to just be very kind of low tech and creative here. And turn the computer. Oh, she can't do that.
I think you'll have to unblur your background.
Okay, that doesn't work.
afterward.
Maybe if we do it this way.
Myself rated me 3, maybe 2. Okay,
It doesn't work. It just makes it fuzzy.
I can see it, but it's because the background is blurred, I guess. So I think you'll have to unblur the background.
Okay. Camera. Oh yeah, we are on blurred. That's why.
Yeah.
Okay, so now let's see.
Perfect. Thank you so much.
Can you see that?
Yes, I can.
Okay.
Thank you.
Okay. Hopefully you'll be able to hear me too, because I'm standing behind the computer. Just yell
can
out
hear
if
you
you
well,
can't
thank
hear. Okay.
Thank you.
All right. So at the beginning, I just want to talk about communication generally and how communication affects healthcare. So we all know that we have to be good communicators. In medical school, we do training, how to do an interview, how to show empathy, how to deliver bad news, these kinds of general things, right? But we don't spend a lot of time talking about the evidence around it or the specific kinds of interventions that you can use that we know actually increases outcomes for patients. So just a few little points that I wanted you to be aware of. So satisfaction with communication is correlated highly with adherence to the medical plan. So what increases satisfaction with physician communication? A bunch of different things that we're going to talk about. So basically, if you communicate well and people are happy talking to you and happy taking your information, they stick to the plan more, they have a more positive view of you, which in turn makes them more adherent to their plan. It decreases physician complaints, which is a nice thing and important as well. And it actually also is positive for the physician. It increases the physician's view of the visit productivity because communication is bilateral, right? We don't just give information, even though a lot of the time we feel like that's what we're doing. And when we chart, that's actually what we chart, what we tell to them in terms of their impression and plan generally. But it is this bilateral kind of communication. So what are some of the things that you can do that helps with patient satisfaction and therefore better outcomes for your patients and just a better interaction between you and your patients? So patients really care that you care. That doesn't sound complicated, but we don't think about that a lot of the time. We do want to connect. We learn very early on how to develop rapport, but it goes even beyond developing rapport. Patients want to know that you actually care about them and their outcomes. And in fact, when you ask patients what's more important and what's more likely to increase their satisfaction and their adherence with the medical plan, clear medical information is important, but it's not nearly as important as their concern, your concern for their feelings. So that's kind of a strange thing to think that the patient cares more about you caring about them than that you've given them the right information. And of course, it's both of those things, but it just highlights how important it is for them and paying attention to that in your interaction. I can't talk about communication without talking about trust and trustworthiness. And I've done leadership workshops, for example, for medical leaders on trust, because it's a big issue in healthcare, developing trust and using trust in healthcare teams, for example. So I just put this out there as a tidbit so that you're aware of it a little bit. And if you are interested, there's lots of interesting things to learn about it. So trust is the basis essentially of communication as well. So a willingness to accept the communication, a willingness to enter into a relationship at whatever level that relationship is. And we really can't help patients very well if they don't trust us. And I'm sure you've come up against situations where a patient may come into the hospital already not trusting of the healthcare system. And that you can feel it from the beginning, and you can see all the different ways that that affects our interactions as they move through the healthcare system. So, but the piece that I wanted to impart to you today was about trustworthiness. So this is Baroness Honora O'Neill, who's a British philosopher and member of the House of Lords, and she has a TED Talk about trust and trustworthiness. So if you have any interest in it, she's a good person to listen to. She's spent her whole career studying this. And it boils down to her saying, you cannot make someone trust you, like you can't. And sometimes we get frustrated with that, right? Like I keep telling them that this is how it is. I'm being transparent. I'm not hiding information. They still don't trust me. You cannot make a family, a parent, a child, whomever you're working with, trust you. What you can do is give people adequate, useful, and simple evidence that you are trustworthy, right? So you have to basically focus on yourself, your behavior, and your communication to demonstrate your trustworthiness. And you do that in lots of ways, right? By being consistent, by being kind, by being compassionate, by having good information, by saying what you do know and what you don't know. And that's not something we talk a lot about in medicine, except that in child and youth protection, we talk a lot about it a lot because we have to transmit information to other systems like the legal system. And in that kind of setting, it's really important to say, here are the facts and here's what I know. Here are the things that I actually do not know. But in all areas of medicine, that's often a good way to approach communication so that people are really clear about where the gaps are too. Okay, so communicating trust then, how do you do this? What is trustworthiness? So I don't know if you can see it there. This is actually from Keynote, which is why I had to change my slides a bit. Trustworthiness so this is taken from the business world. So there's also lots of study on trust in the business world and the nonprofit sector in all different areas because it's key to everything. It's key to all relationships. And everything we do in life essentially boils down to relationships, right? So this is a particular model that is often used of trustworthiness set in like a mathematical model, essentially. So high credibility, high reliability, and high intimacy. And intimacy just means like being a human person. It doesn't mean obviously being like personally intimate or sexually intimate or anything like that. It just means that there's some level of intimacy in the relationship. It's some vulnerability in the relationship. Those things increase trustworthiness. Okay, so you guys are generally credible. Just by the virtue of the fact that you walk in and say, I'm Dr. So-and-so, you already have high credibility. So our issue usually is not losing credibility, right? So it's about making good use of that credibility that we walk into the room with. Reliability, you do what you say, you're consistent with how you do it, those kinds of things. And then intimacy, which is really connect with the patient or the parent, right? So this comes up a lot in child protection work, and we see when people get upset, particularly if they come into the emergency department and somebody says, you know, we need to admit your child and we're going to look for other injuries. How you deliver that information makes all the difference to how the parent interprets it and then moves forward with us or doesn't really move forward with us in a sort of aligned way. So being vulnerable or showing that you have those feelings as well is very helpful to be able to let the parent have emotions, because would you not if you were in that situation, right? To validate those emotions. Yeah, you look super angry. You look really upset at this moment. I totally get that. I like feel the same way if I were in your shoes. Like just really being a human with them, as opposed to my legal duty, I have to report it, right? That's creating the wall. So that is true too, and you might have to explain that, but it's how can you connect with them? How can you be on their side? Yeah, I'm really worried about your child too, and it sounds like you don't know what happened or your child had a fracture. I don't know why that happened. Let's work together and see if we can figure it out, right? So it's the same information, but coming from like a different side, okay? Self-orientation decreases your trustworthiness. So that means a focus on yourself. So if it becomes about you as the physician, well, I need to do this, I need to do that, I need to get out of here, I only have this amount of time, blah, blah, blah. Those kinds of things are true, and they are practical realities and limitations in our lives. But if we can learn to essentially not communicate those out, then that will not decrease our trustworthiness, okay? The second thing is once you've done all these things and you've built up the trustworthiness, then the other thing that really helps establish trust is actually offering trust to the other person. So even in that kind of environment where it might feel conflictual with a parent, for example, demonstrating your credibility, reliability, and your humanity, and then offering them trust. So whatever it is that you can do to sort of say, and I trust you to do the next right thing. I trust you to, I know you also want the best for your child, right? So it's extending that trust. So again, it's this bi-directional kind of communication through trust that actually builds trust in that relationship. Does that make sense to people? Okay. Okay, we're going to move on to sort of starting to think about messaging, because I'm supposed to be talking about media. So when we start talking about messaging, we have to think about who our audience is. And I don't think we think about that a lot in healthcare, right? But when you write a note, who are you writing that note for?
Typically doctors.
The family doctor. Who else?
Well, reference, sometimes for legal purposes.
Okay, so that's fine that you're writing it for yourself to make sure that you fulfill your duties.
To the school.
Could be to the school. Yeah, could be to a lot of people, right? But more increasingly, it's the family is also going to be reading those things, right? So it's thinking about who are all the audiences of this as you're writing it, right? And that doesn't mean you have to change everything about it, but being aware that will sometimes change how you want to put down that information. In my world, it's parents, child welfare workers, police officers, foster parents, advocates, lawyers and judges, researchers, lots of people are using that information. And so we spend a lot of time, if you've come through CYP, it's probably intensely boring for you guys, like humming and hawing about how are we going to say this and what words, and are we very concerned, or are we like all this sort of silliness, but not silliness around what are the actual words that we're going to use. But in any messaging, you want to think about who's going to be reading this, and because that shapes what your message is going to be. And then when you break it down, you know your audience, then you need to know your objective. What's the point of this? So the point of documenting something for legal purposes is very different than documenting it in a letter to give the family doctor instructions, or very different for the school, because then you want them to use that in a different way in the educational setting. So what's your objective? Because if your objective is clear, you're going to know how you want to tie that up in a bow at the end, as opposed to, I'm just going to throw all this information on the page, right? And then it's going to be way more useful for that audience, whoever the intent is. So I work in a bunch of different places. One of the places I work at is 360. If anybody's been there or seen letters coming back from there, it's great. Roger Zemek has it all set up with lots of clicks. It's all very templated, mainly because we extract all the data. But I always put a narrative paragraph at the bottom of it, partly because if I go back and look at the chart and I even know the patient, if I just see all the things that are clicked, I can't really figure out exactly what's going on with that patient. But if I write 2 sentences at the bottom and say, this is what happened and these are the main concerns currently, and this is what we need to watch for at the next appointment, it's super clear, right? It's clear to me, it's clear to the family doctor, or next steps would be X, Y, Z. I told the parents X, Y, Z, etc. So if they go to the family doctor, they can hear it too. So the more that our things are templated, I find the less understandable they actually are in terms of understanding that whole context, right? The other thing that CHIO does is we document by exception or document by exclusion. So you assume it's normal unless it's clicked, right? For in some of the documentation. That's actually not super helpful because we don't know what you asked and what the person responded. So you just have to be careful of that. And AI is doing similar types of things. So it just means that whatever it is, you need to be efficient. That's all really important. But paying attention to that documentation, who's it intended for? Are you going to meet your objective with how you document? Okay. Then there's the creating the message. So we're going to go through from a journalistic perspective. What we think about in journalism is a lead, which is the hook, the nut graph, which is the context, and then the body, which is the details. And of course, we want to use plain language, and I'm going to just touch on a few words that can give people difficulties sometimes. So medicine is its own language, right? We have our own abbreviations. We document in specific ways, but we also use words in ways that I will say normal people don't use them, right? We use the word mom and dad referring to somebody, whereas if you were talking to somebody outside, unless it was your own mom or dad, you would not be saying mom, blah, 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 dad, blah, 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 right? So even in the very basic ways we communicate, it's different. Parents don't love that. A lot of parents are fine with it, but most people don't love it. We all do it because it's the easy shorthand way of doing it. But if at least at the beginning you can put the parent's name or say child's mother or whatever it is, then I think it's a little bit more preferable. There have been some studies that this has come out in. So it's one thing just to think about. And also maybe calling them by their name if you can. And asking how they want to be referred to, right? It's part of that establishing trust, being human, that intimacy level. Poor historian. I don't know if you guys still write that. We used to write that in church when I was a resident here. It's not a very nice description of somebody and how they're telling information about their child, right?
In our like admission note template, there's a reliability section where you fill out, which I always erase because
Yes.
it sucks. Yeah.
Even the word reliability,
Yeah.
right? Parents is like, what? I'm not reliable, right? They're going to understand that differently than we do. So just giving a description, a lot of the time it's just describing, oh, parent couldn't remember some of the details, or, you know, parent is very tired and not wishing to elaborate, or whatever it is. It gives you the flavor of what's happening, but without kind of labeling it on the parent. Denies is a big one. So if I had a sister and I said, I don't have a sister, but she denies smoking, what does that mean?
You don't know if you smokes or not. You don't know.
So usually it means she smokes, but she says she doesn't smoke, right? That's how denies is used most of the time.
Oh.
Yeah.
I mean, it wasn't that for me, it's just I don't know because, well, I don't know.
Yeah. So we use denies to mean no, right? No smoking, no pets, no whatever. But if somebody reads that chart, they're going to think, but I don't, I'm not denying it, I just don't, right? So it's another word to just be careful of. Unexplained is a word in my world because we talk about unexplained injuries, but we have to be careful about that because a parent might have what they feel is an explanation for it, even if we don't agree. So they wouldn't say it's unexplained. I've been called out on that many years ago and I no longer use it. These are also things in the child protection context. So consistent with is a terrible term. Lawyers think that that means if I say the bruise is consistent with this, they think it means it was caused by this, where I mean it could have been caused by this, right? So we specifically do not use that. That came out of a judicial review. Evidence means something different in court, so we just don't use that. Accidental and non-accidental. So lots of people will use not accidental or NAI. I personally don't use it because I can't determine medically if something is an accident or not an accident. So in the literature it is what's used. It's kind of shorthand, but I don't use those terms. If a child were to run out in the street and I grab them, hold the back, I could cause an injury to their arm. If the child was standing there and I was angry, I could reach out and grab them, hold them back, and they could have the same injury to their arm. How can I tell if it's accidental or not accidental? The history doesn't tell me. The history may not tell me. I don't know what the intent was. So I don't use those terms. Abuse is not a medical term. It's a legal term essentially. And shaken baby syndrome, I hope nobody's using that anymore. Great. Back in the day, we all used that. It took us almost 15 years of working with all these people across Canada to try and get that out of there. But to have the symptoms, you don't have to be shaken, you don't have to be a baby, and it's not a syndrome. So terrible name. So just two that we use all the time, and just to be aware of, if you're ever in a legal contest, investigations mean something different to investigators, right? So I rate medical testing. I don't rate investigations. And impression, this caused problems for me in court too one time. They said, so it's just your impression, doctor, like blah, blah, blah. Right? Which doesn't sound like I'm confident about what it is that I'm saying. So we use that in general language, like, oh, my impression is this. It doesn't mean I know that it's this, or this is my opinion, this is my clear opinion. So I also don't write that anymore. I write summary. But you can write whatever is appropriate in your context. And for most of you, it's not going to be an issue because you're not going to be in court answering for these things. But it's just sort of a reminder of the very basic words that we use are interpreted different ways by different people.
Sorry, I'm just wondering how you say like accidental versus non-accidental. What's your kind of preferred phrasing?
So I talk about if we're looking at a child who has some kind of injury, we have injury here, and then there's kind of two different streams on our chart, right? One is medical conditions, one is trauma, and then you can have a combination of both. You can have a medical condition and trauma that has caused the fracture, the bruise, or whatever it is. Under trauma, then what I say is birth trauma, so trauma caused by birth, trauma caused by medical intervention, so chest tube, CPR, whatever it is, trauma caused by the child, trauma caused by somebody else. And I define that as inflicted. And so I will say, in my opinion, the most likely cause is trauma. It could not have been caused by birth. It could not have been caused by the child themselves. There was no medical intervention that would account for it. Therefore, the most likely cause is caused by another person. And then I will say, i.e., force applied to the child causing the injury, causing the fracture, or causing the bruise. So I say more words, but just very directly about what is it exactly that I'm doing. If I'm going to say something is accidental, then I will define it. Because sometimes you have this conversation with people and they're like, what do you mean? And so I'll say like children's bruises here. I will say normal childhood bruises as opposed to accidental childhood bruises. But if they really don't get it and they'll say, do you mean it's accidental? I'll say, yes, it's accidental, meaning it was caused through the child's own normal activities. So I just use more words to say exactly what it is I mean. Inflicted is another term that I use. So inflicted is the same as caused by another person, right? But you can cause something and it wasn't non-accidental or abusive or any of those things. I'm basically saying from a medical perspective, I think somebody else caused it. And then you go into like how ways that can happen. But I really can't say this is an accident, this is not an accident. Because I don't know the intent. Does that make sense?
So for example, in the chart, if I have a kid that I think it was like an inflicted bleeding, like severe bleeding, so I say inflicted head trauma. Okay.
So I would say traumatic brain injury, because that's our medical diagnosis.
Mhm.
And then I would put a secondary diagnosis, however you want to put it. So you could put social concerns or something that flags that there's some concern, right? And because really it doesn't matter that much in terms of the diagnosis being accurate that way. That's just going to be coded for billing and things like that. But that matters a lot if a lawyer looks at it or a parent looks at it or whatever, especially if people are writing different things. So I always say, just stick to the diagnosis, like traumatic brain injury, subdural hemorrhage, bruising, whatever it is.
Okay.
Yeah.
Dr. Wood, is there a movement to try to remove accidental and non-accidental injuries like that language? Because that's how we see it through CPS statements. That's how we diagnose it. That's how we flag it on our notes. Like if I have these social concerns in my admission note, the next morning team isn't gonna necessarily think. I mean, I can describe the incident for sure, but
Yes, or child welfare involvement or whatever it is. So yes, and I'm on a lot of those CPS statements, and we have this conversation with every single one. There is variability. amongst different people, even in the center, I would say. And so I think in some ways it's less important the word and more important to have you explain what your words mean.
Okay.
Yeah, so I would love if people didn't use it, but then you would all have to agree. It literally took us 15 years to get the government and CPS to remove the shaken baby statement, shaken baby syndrome statement. We had to do like roundtables and language consultations and all this stuff. So while it might be a good thing, it's never gonna. Okay, so I can't see the time on here. Oh, there it is, 3:30. Okay. So journalism. So why am I talking about journalism as a physician? I put this up because in just before COVID started, the year of COVID, essentially, I decided I was going to go back to school. I was on like a part-time sabbatical here, kind of still doing call and stuff, but also doing this. I went to Munk School of Global Affairs at University of Toronto to do this program, and I happened to be staying that night with my brother and his family in Toronto, and his kids were all standing with their things for the first day of school because it was the first day of school for them. So they made me stand with the thing. And what we figured out was it was grade 25, which was really like sad. That's how many years of school I've done. But anyway, so I went and did a 1-year program. If anybody is interested, they have now programs that are shorter and you can do it more easily while working and doing other things. There are residents who have done the program, but they've taken some time off or they've done it as a sort of an elective in a different way. When I did it, it was a year-long program. They took 20 professionals and essentially trained you to be a journalist to report on your own specialty. So there were a couple of physicians, a couple of lawyers, environmental scientists, military, financial people, all different kinds of nonprofit. And they basically were giving you all the journalism skills so that I could be, for example, a health reporter. And the whole program was done in the real world so that we would pitch out to all their partners that were like the Globe and Mail and CBC and the Walrus and whatever, all the different media outlets. And if they liked your idea for the story, then they'd be like, yeah, they want your story in 48 hours, go, kind of thing. And you would do it so that by the time you ended the program, you had a portfolio. So that's what I did. And I did it because I love communication. I want to do something different. I wanted to use the other side of my brain. I've been doing the work here for maybe 17 years or something like that. I had already done a bunch of programs in knowledge mobilization and knowledge translation, but wanted to do something kind of out of the box. And I just thought it would be fun. So I went and did this and had an amazing time. But why is working with the media important generally? So as we've talked about, medicine is communication, and communication can be medicine for your patients, right? So just thinking about communication in a different way is important. The research we do, the knowledge we gain, and the wisdom we have needs to be shared to actually make a difference. And I think that's what really motivated me. I thought, I hear so much information, so much interesting information, all the rounds we go to, all the innovations, and nobody outside really knows any of these things, right? And yet they're going online, Dr. Google, and doing all kinds of things that make no sense, even when we have all this great information. So that was part of what motivated me. You can definitely reach more people. You can start new conversations in the public sphere, and I'll give you some examples. You can help the public be knowledgeable and empower them to seek good information. Right now, a big issue, obviously, is counterbalance the misinformation. And I think we need to know how to do it well, even if it's just the principles of communication and thinking about it in a more kind of deliberate way for our roles. And there's a changing landscape. So about the changing landscape, this is, we already talked about that. Oh, I was going to give you an example first. So this was the first thing that I wrote about. So I saw in my CHEO email, the Emerge sent out a note to say we're no longer going to be using Benadryl and carrying Benadryl in the emergency department. And I thought, that's interesting. I didn't even know that. What is that about? So journalism is really about being curious. So I picked up the phone, and luckily I know people here, and it's like, okay, what's this about? Tell me what it's about. And they explained that it's really not recommended, the safety profile is that it's good, et cetera, et cetera, et cetera. I was like, okay, interesting. Do people know this? So I went looking. No, I couldn't find this anywhere, right? But there was a statement that had come out through the Allergy Association that had been published in a reputable journal, Allergy, Asthma, and Clinical Immunology. But who's reading it, right? And so I asked a bunch of people, pediatricians, family doctors, other people, like, do you still use Benadryl? Everybody still has Benadryl. Everybody still has it in their homes. They're still giving it to their kids. They were recommending it for patients. I was like, this is the message that needs to get out. So based on that, I reported it. I interviewed a whole bunch of people. I learned the science around it. I pitched it out. And lo and behold, people really cared. So I wrote that one for the Canadian press. The Canadian press is the wire in Canada, which means that there's all these different media outlets contribute some money, and people can write to the Canadian press, and they bring in freelancers as well. You can write something, it goes on the wire, and then any of the other organizations can pick it up and run it through their outlets. So for me, it's where I love to write, because you would put it up and then you would just watch, and like 10 minutes later, it's hitting CTV, and 20 minutes later, it's on CBC, and it would just kind of go. And this was like wild for me. So it led the National that night, the story that I had written, not me, but the story led the National. And when I got on the subway to go home that night in Toronto, it was on the ticker in the subway system. So I was like, people are going to know now that they shouldn't be using Benadryl, right? And then they wanted a follow-up story, and what's the opinion of pharmacists, and what do we do about that? And so then I ended up writing about Benadryl, which was like not something I was particularly interested in. But I thought, well, I was really doing it because I wanted to learn the mechanics of how do you write a story and how do you get it out there. And it just kind of happened to blow up. So that article ultimately was accessed 58,000 times. Imagine how many times it would have been accessed. Otherwise, probably like 100, 200 times, right? And the lead source that I used, I called them back afterwards, and after it kind of all blew over. And this was like, I was back and forth with Health Canada, and what were they going to say about it, and what's going to happen, all these things. There were all these things happening. Everybody was kind of worried from the program that somehow we were going to get sued by the pharmaceutical industry. Like it ended up being this really big thing. And I called him back, and he's like, oh my gosh, like this just took over my life, because everyone wanted to talk to this guy. He was on every radio show. He was on everything. And he's like, but thank you, because we had published that months and months before, and nobody cared about it, right? So great information that just didn't get out there. So why did this message resonate? This is what we often talk about in journalism. So a simple message: don't use Benadryl. It's not good anymore. Basically, that's not what it said, but right? It's a simple message to understand. It's relevant to so many people. Everybody knows what Benadryl is. Many people have it in their cupboards at home. So it's really relevant. It's urgent because there's something new that happened. So news is only news if there's something new, right? And it was new that now the allergists had come together and said, you shouldn't be using Benadryl, right? That was new. And then, oh, it doesn't show very well. It's unexpected. So it's kind of the opposite of what people expect to hear, right? People expect Benadryl is a good drug and it works well. So when you say the opposite, that catches people's attention. I think this is also illustrates why it's important for us to speak and for us to get our voices out there. So this is from the Edelman Trust Barometer. It's Canadian data. And when you ask people, oh no, so this one was global, but there is a Canadian version. When you ask people the percent that trust to tell the truth about health issues and about how to best protect the health of the public, 80 is the score for physicians. 76 is the score for my friends and family, right? Global health authorities are 61. So who are people believing? Their friends and neighbors. So who do we need to get our messages to? Their friends and neighbors.
Yeah,
Right?
TikTok.
Right? Yeah, exactly. That's where people are getting their information, right?
You should have a follow-up on the Benadryl challenge.
I know, it's still ongoing.
Yeah.
No, I mean, the problem is still ongoing.
Yeah.
Yeah.
QIC admission.
Yeah. Interesting, because during after COVID, we were going to do a story about overdoses because everyone was home all the time and all of these kids were ingesting all kinds of things, and Benadryl was one of the top things as well. And trust in the media's healthcare reporting is plummeting. So that means it's important that people who are credible are the ones who are speaking, right? Because people are now discerning sometimes about who the sources are. The other thing that people say is talk to me like I'm your equal partner. Don't talk down to me. Don't be like, I'm the doctor, I'm going to tell you what to do. That they are trusting and again, enter into that relationship. If you really talk to them, that's the extending the trust. Like I'm going to trust that you're going to understand the information I'm giving to you, right? Talk to them as an equal partner. And there's actually statements from all of these organizations about how we need to do that sort of communication. So, okay. Back to journalism. What can you do? So when I sort of started my program, I was like, I just want to do something. I didn't really know what I wanted to do. Of course, I wanted to talk about the issues that I see for marginalized families and the difficulties for these families traveling through the healthcare system and all the legal issues that I see. And none of that stuff ever gets talked about. As it turns out, people don't want to publish stuff about that. So that is very difficult. It's actually difficult to get pediatric things published because kids aren't the ones reading it, and parents really care about their kids, but they aren't so much interested usually in sort of kids in general, right? But because of the COVID-19 pandemic, it presented this real opportunity and it changed things. So we started seeing an increased number of kids with head injuries during that time. And I went to our media people and was like, I don't have data. We don't know this yet. We are studying it. We have a multi-centers trial going. But this is my experience, and whether or not it's true, I think it's a valid concern. And so I pitched it out to a bunch of places. It was on the wire again, so it got picked up in all different places. So it gets picked up by big places like Globe and Mail, and then it's also like the Winnipeg Free Press or whatever. It kind of gets picked up all over. And so I actually wrote this article, but then people started contacting me as kind of an expert in the field, which is unusual for somebody who's working as a journalist. You can't really be on both sides of it. But as a health professional, sometimes people will ask you to play both these roles. And so that was really good because I got a message out that I thought was important, and then I was able to capitalize on it. So then the morning show in Ottawa decided they wanted to do a thing, CTV. So then I was on news, I was in print, I was on radio, and it just kept getting covered in different ways. And it's not my work. I'm just explaining what's going on. I was explaining what work was going on in different parts of Canada to try and help with this, what people's concerns were. And it just raised the public interest in it. And what I kept saying is home is not always a safe place. That was what I just kept saying to try and explain it to people, that most of the time it is, but it's not always a safe place. And as a result of this, and then working with people in that field, we actually got it all the way up the chain and started to hear that the federal government was talking about this as a potential issue and what they could do about it. And I don't know if you remember, but Prime Minister Trudeau at the time used to do a Sunday public briefing. So he used to speak every Sunday and give like a short little update on what was going on. And he actually used that as his topic about 3 weeks after all of this started and said, home is not always a safe place. What our government is going to do is invest all this money into Kids Help Phone and some other resources. So again, it's not because of my work. It's just me raising the awareness and bringing other people's work to the forefront, but it changed the public discussion around it that then put pressure on the government to have to respond and do something, right? So that was a really interesting experience. Out of that, then I thought, okay, now what else can I do? And I was hearing from my colleagues in the community, like advocates and children's advocates provincially and things like that, that one of the big problems during COVID was that kids were aging out of care and they had nowhere to go. So if in some provinces, if you turn 18 or 21 and you're in foster care, you're literally like you can no longer stay in that placement. Move out, but it was COVID, so there's nowhere to go. So one of the provinces decided that they were going to put a moratorium on it, and so long as it was the pandemic, everyone could just stay where they were. So I heard about this before it was announced, because I just knew people in the space. And so I picked up the phone and called the Minister of Health for every province and said, hi, I understand that, you know, this is happening in this other well, first I confirmed it. They said, yes, we haven't announced it yet, but we are, and they can't tell you not to talk about it. It's one of the great things of the journalist. You have information, you have to use it. So I called all the other provincial ministers and basically said, this other province is going to do this. What are you going to do? And then they were forced to respond. And in the end, then all the provinces kind of fell in line. So it's, again, it's a way of advocating in some ways, not by doing the advocacy, but just by raising that awareness and poking at people to say, what are you going to do? So that was another fun one. And then I kept trying to pitch this topic. So I think epigenetics is just so interesting, and how the very basics of parenting imprints on our kids and shapes their health for life, right? But how do you get somebody to write about that? So finally, I kept pitching in different ways. And finally, I was like, Mother's Day. I'm going to pitch this for Mother's Day. And so I did, and then that got picked up. So I was really pleased, because I was like, this is a message I really want to get out there so people just understand it and even know the word like epigenetics and things like that. And that finally got it. So that was a fun one too. Okay, and then you start getting asked to do different things. So I wrote about all kinds of weird things, like the Montreal Children's Hospital was treating adults during the pandemic. And in Hamilton, the hospital was using baby monitors in their emergency department to communicate inside and outside the rooms, because they didn't want to open doors, and like just weird things that people are like, wouldn't know. Anyway. Okay, so what time is it? Okay, perfect. So how do you decide what you're going to do if you have a message and you want to get it out? So the first thing is just think. I know that sounds really basic, but it's like you have to actually sit and think in sort of a deliberate way. Like, what am I trying to do? Who's my audience? What's my goal? How do I want to get my message out? So I usually think kind of, okay, what's the issue? Who's the audience? What's my objective? And then what's my message? And then I write what's called a focus statement, which is basically, this is happening because of this, and this is the change that it's going to have. So it's like you plug in, pharmacists are saying Benadryl is no longer safe, therefore parents should no longer buy Benadryl, right? So it's like a very simple, like, try to boil it all the way down. And so what I want you guys to do is think about something that you think is an important message. It could be related to your research. So you can pretend, if you haven't finished your research, what a message might be in your research. It could be from your advocacy work. It could be like a clinical issue that drives you crazy, right? There's usually something that you're like, oh, why does this always happen this way? So think about something right now. Okay.
And this has already been like written up in articles too, and by different journalists, but just like reframing like vaccine hesitancy, what that looks like in Canada. We are not safe. Like, we're not fully vaccinated for measles. There is no herd immunity anymore. Like, just like actually highlighting that to the public in a way that is transferable to them and it's more tangible than like looking at numbers and the use of herd immunity. What does that actually mean? And kind of reframing that as well. So yeah, that would be my message, especially with.
So what you're talking about is actually the angle, which is really interesting, right? Because vaccines have been written a lot about, but usually the message is parents should vaccinate their children, right? Vaccines save lives. What you're talking about is you're coming at it from a different angle. You're coming at it as, we're a herd and we are no longer safe as a group, right? So that is actually a different message than usually gets out there. So that's good. Like, that's what you want, and especially if it's a topic that people have already talked about. You want to come from a side angle. You want to come something that's unexpected, right? Like you over there who doesn't have children and is not concerned about vaccines, you're at risk, right?
Yeah.
Because that's the message you want to get out to people, right? Great. So, okay, have other people thought of one?
There's like so many things that are that
Stick this with gambling is a good habit.
What's it have? Sports gambling?
Sports, like every sports game is full of sports gambling ads. Then like teenagers, as soon as they turn 18, open gambling accounts, which is obviously bad.
And what does it lead to?
Addiction and bankruptcy.
Yeah, okay. Okay, so here, you just said some words that don't usually get put together. Teenagers, bankruptcy, sports, right? So if you can craft something around that, that's like an unexpected message, right? As opposed to saying, like, I think everybody knows that sports gambling is bad and can lead to addictions, but that's a different message. So you could say, I don't know, let's work with that for a second. How would that look? You could say something like,
I don't know. But I don't, but like if you have no, so this is what I was gonna ask again, like if you have no data, because like coming from the medical thing, how do you write anything?
we're gonna pretend to get data.
Okay. Like, I wouldn't be surprised, but I have no data to find out that like teenagers are using credit cards to fund sports gambling that they can't then pay off at the end of the month.
Yeah, what about something like teenage gambling leads to bankruptcy
That's it.
or right? People are like, teenagers bankruptcy, what are you talking about, right? You can't- Right? Yeah, I mean, you can do this with any topic, right? And anybody else? What about something from research or an advocacy project?
Like a lot of people think they're allergic to penicillin.
Yes.
And then 90% of them are actually not.
That actually is potentially like that could be a headline, right?
Yeah.
So the one thing about headlines you should know is the reporters never get to read them. They're like AI generated and by the managers and stuff like that. So there's things that come on mine, headlines that I'm like, I kind of cringe at the headline, but I have no control over that. But something like that, right? So that could even be a quote headline, right? You are not allergic to penicillin, even though you thought you were your whole life. Right? Like that, people might go, huh, really? How come? Yeah, great. That's a really good one because that's an unexpected twist. Yeah. Anybody else?
So many things. I don't, a lot of the things that I think about, there's just no data.
Yeah.
And that's just it. And like, it would be talking about things that I've just seen in pattern.
Yeah.
It's like, for example, these TikTok challenges or like for this one time, there was a TikTok challenge, for anorexia, patients with anorexia nervosa, and who would get admitted first.
Yeah.
And then they would get like really sick, really quick, and they get admitted, but you can't write that up because there's no data to support that.
Yeah. So, okay. So we already talked about reliability and credibility are really important. Right? So I'm going to actually skip down to the bottom here. We can come back to some of these things if we want. So this is taken from when I was doing some training for senior health leaders in different organizations, and sort of we were having a discussion about how do you decide if you're actually going to put yourself out there on a topic, right? And so I think this is a really important thing. Like, does it represent me as a professional? And we as professionals are health-based, evidence-based, right? We try to be objective as much as possible. And one of the things that I found really hard was that you do not need the same level of evidence as you do to publish, to talk about a story, right? What you do is you have to be very clear about what you know and what you don't know. So if you have 3 different experts from across the country who are observing the same trend, that's a story, right? Because most of the time something new is something new and we haven't done all the research on it. Is it going to pan out to be 100% perfect? No, it's like the story that I wrote about. We're concerned that there could be an increase in injuries to infants during the pandemic. I couldn't say there is an increase. So the story highlighted the issue, but then talked about what has been seen in other settings, like when there was the recession in the US. What were the patterns of injury then, and why are people concerned? And then getting different experts to speak to that issue. And that it is a story, but it's not a confirmation that this is what it is. And then some statement about, and the research is ongoing.
Yeah.
Right? Yeah, so that's the thing, like, we feel like I have to know 100% and it has to be a P less than 0.05 in order to be able to say anything, right? And it doesn't work that way in the real world. If you wait for that, it's not going to be news anymore, right? It's going to be 3 years after people start talking about what it is. When it does come out though, and you have good evidence, then that is a news story as well.
Okay.
Yeah. So these are the kinds of things you have to think about. You may be called to participate in something. Sometimes it happens here at GEO. People will ask you if you want to speak to something, or you might want to be on the GEO telethon, for example. I did that when I was a resident. So there might be reasons that you are going to be speaking to somebody outside of the healthcare field and delivering an important message. And how you present that message is important, right? And so going back and thinking through these kinds of things, I want to represent myself well. Is this a message that I want to share publicly? So I get asked to do interviews for things sometimes. And I'm like, not touching that. Like, that is going to blow up. Nope. Or that is not in my area of expertise, but I can put you in touch, or I can ask this person if they're willing to speak to it. So that is something that's important to stay in your area of expertise to maintain your credibility. Do I need to talk to my organization? So if anybody reached out to you and said, oh, can I interview you about XYZ? Technically, you're supposed to call the comms director here and let them know, and they would prep you, hopefully, or you can call me and I can help you if they agree. Because you have to know who you're speaking on behalf of. Am I speaking on behalf of GEO? Am I speaking on behalf of Michelle Ward? Am I speaking on behalf of CPS? Who am I speaking on behalf of? It's at the time, am I the right person? And we're going, no, I might not know. So we talked about that. Okay, I'm going to go back just to a couple of things. I thought this might be interesting to share. So my cousin is actually the national health reporter for at Global. She's an on-air person. Her name is Catherine Ward. So if you ever see a Catherine Ward who looks like me, but is taller and younger, which is totally unfair, that's my cousin. And we have done some of these trainings together. And one time she actually videoed herself, created a video of what she does in a day to get a story out. And I think it's important for us to know because, again, in some cases, the media is our audience, right? If we are trying to get something out to the media, and there have been stories that I have picked up the phone and called like a radio station editor and said, are you interested in a story on X, Y, Z? So in that case, that is my audience, and I'm crafting my message for that audience, right? So what happens in the morning, which starts early, so the pitch meeting starts at 8, and this is how my program works too, which it's like handover, basically. Everybody gets together and they pitch the stories that they think they want to do for the day, or the editor is saying, you're going to go do this and you're going to do that. And there was a fire overnight, I'm going to bring that, and there's this court case and we need somebody on that and whatever. Okay. And then you do what's called the chase, which is basically you're trying to find people to speak to that issue. And of course, you want to find the best people. And the best people are people who know a lot about the issue and are what we call good talkers. And a good talker is clear, can speak to something in simple language and in short bites, essentially, right? So some people are amazing experts and they cannot give you a statement, especially if you're on air or radio. So if somebody wants to interview you on air, you have 20 seconds for each answer is optimal or less. So you're basically saying 2 sentences for each thing they ask you. So you have to know what it is that you're going to say. If you're doing a print, so if it's going to go like in a newspaper or an online forum, then you can say more. And you can also then correct yourself. You can say, wait a minute, I want to take that answer back and I'm going to say this instead. Right? even if you're on air, it can be live, it can be taped, it can be live to tape. So it depends, you need to ask, how does this work? Like, am I on the TV or online as you're talking to me? Or are you taping this and then editing it or whatever? So you can ask all these questions. So you go out and you chase, you get all these interviews, and then you have your information. Basically, there's probably background information, like reading studies or whatever else. And then there's a really quick turnaround. So these reporters, thank God I don't work in that kind of environment. I haven't even been doing this recently because I just have not had time with my clinical and other work. But when I decide I'm going to do a story, I do like tons of research and have lots of time to think about it. These people are turning it around in a matter of a couple of hours, right? So, because every day they have to produce. They have to have all these segments on air. So they're trying to get it done. So if they call you and say, could I interview you? You can say yes or no, but you can't really say, can I talk to you next Tuesday? That it's not going to, right? Live, so they'll go to live hits, which means that like that's the person on the street, right? Like I'm interviewing you right now and you're on TV and that kind of thing. Then they monitor what's happening with that story. So if it's like the government's doing something, announcing something in the morning, and then people are going to be responding to that, then they want to follow what's happening in development, and they might have to package that up and deliver it out. And then they want to have their like final content for the evening run. So you usually get bits and pieces during the day, and then they repackage it as like a whole story, and then it goes out for the evening run. And they might still be doing live hits, so they might still be people out, getting people to talk to that issue. And then you start and chase for the next day. So it's just this like crazy 24-hour cycle that regular journalists are working on. And so sometimes you'll see, a lot of the time you see content and you're like, well, that's not very well researched. And that's actually true all the time. Which is another reason why I say people like us should be doing this, because we can bring a different depth to the information, right? And correct. Sometimes I see things that are not correct, and I will now call, because it usually says, right, who the reporter is. I'll call them and be like, just so you know, that's not really right if it's a health issue, because it also holds people a little bit accountable. Okay, I think we are not going to do mock interviews, but the last thing I want to do is say this, which is kind of a simple message, but it's a different way about thinking about communication. So when we are taking information, we have a specific way that we take information in a medical history, right? And we start with a little bit of information here, and then we get more and more information. And then somehow we have to summarize this information, right? So it's kind of like this shape. When I used to teach history taking at the medical school, I used to tell them to try and do this, so that every time you go to a new section, like you do HPI, and you're getting more and more information. And then when you go to the next section, you want to do the same thing. So you don't, by keeping open-ended, right? Another way to describe it is that you are very open at the beginning, and then you're kind of tearing down your information to what your impression is. So it depends how you look at it. But what I say is more effective for communication based on knowledge mobilization and journalism techniques is start with your star. What is the most important thing you want to say? We always say that at the very end, right? The poor family doctors have to read like all this stuff. But even for patients, we explain, okay, well, we think you have asthma, or we don't say that. We'll say, you came in and you had this and you had that and the puffer health and blah, 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 blah. We think you have asthma, right? We've kind of lost them by then, because they're not still going to be retaining information at the same time. So what I try to tell people is hit them in the face with the most important information. So when you're seeing somebody, you know, oh, I know you have a diagnosis of blah, and the most important thing we're going to talk about today is blah, or whatever it is, okay? Same thing goes if you're writing something like a poster, or you're doing a presentation. Tell them something up front that's going to give them interest. That's your hook, right? That keeps people interested. Then collect your information, get as much as you can, go as broad as you need to, and then come back in slowly. So don't arrive at like a steep peak of information. So keep going broad, keep asking more questions as you're kind of funneling all that information. And then you have less of a chance of missing something, because what you don't want to do is get to the end and you've missed something, right? So at the end, you're basically going to be confirming what you set up here, which means you have to have done all this to say this, or you use this in the context of, okay, now we're going to have a discussion based on everything I've learned from you today. Okay, and then you go, the most important thing is this, and being able to be very clear with people and say, this is important, like explicitly, right? It's like a staff are told to say, so I'm going to teach you about something now, right? This is a teaching moment, so like it makes it really clear. It's the same thing. What I want you to know about your child when you leave here today is the most important message I want you to hear is, because they might not remember the rest, right? So be really explicit. It's your headline, okay? And then give them the rest of the information. Why is it important? All right, we sort of did what I was planning to do and sort of didn't. Do you guys have any specific questions? Anything you want to ask? These are just other things I used to write for Today's Parent, which no longer exists, which was a magazine for parents, which I thought was sort of fun. And it's like, people are like, so lowbrow. I'm like, yeah, because who do I want to read? Parents. So I don't want it to be in the Globe. I want it to be in the magazine that the parents read. So I used to do a year end, like, here are a bunch of things that pediatricians learned this year that parents should know. So new guidelines on fever or new whatever.
Love that in the community. This reference today's.
Yeah. So
Not playing the thing.
yeah, I mean, they don't.
You ask questions, you're like, I don't have a child, I don't know. I know the medical stuff,
Yeah.
even the textbook, what Nelson says.
Yeah, you learn all
Now these parents something, because like when I put things to our parents, they can't, there is something parents.
Yeah, the CPS has a parent side.
But then there is something about parents, not all of parents.
Gonna have to get.
Yeah, Ottawa Public Health has a nursing site, and they have a bunch of videos actually, which are great, and content. Yeah, it's lovely. This one was funny. I just stumbled across actually because of what the Benadryl. I've been writing about all these over-the-counter things for some reason. Because I had all these. The other thing that you do as a journalist is when you have a good source or a good talker, you say, what else is going on in your field? Anything else you think I should know? And inevitably there's something else. So then I ended up writing all these weird things about over the counter. But one of them lead to the fact that you know how there's Orajel for babies? So it was pulled from the Canadian market, but nobody said anything. Like Health Canada, it was banned in the US. Health Canada then asked the manufacturers to pull it, but there was no announcement. And so all of a sudden it's just gone from the shelves, but nobody knew it was gone from the shelves. And I'm like, that's pretty sneaky. Because it could have been a problem, right? There's all this safety data coming out, so it could have been a problem for the manufacturers. But so I wrote a story about that, how it just kind of disappeared.
Do you ever get responses to like, I would guess that what keeps a lot of physicians from writing in mass media is like a worry about A, that they're not an expert enough, and B, that they're gonna get responses but they don't have time to deal with, or that they don't want to bend. Do you ever get like critical letters back for the articles you've written?
I've been pretty lucky, and also because I've written for mainstream media, you can't comment for the most part for the things that I'm doing. I have twice written things where somebody who I had been part of the story or peripherally part of the story disagreed with some of the information. And that I did have to deal with. And so that's not easy because you don't, especially as a physician, you're interviewing a lot of people who are essentially your colleagues, right? And so you need to maintain your reliability and your credibility within your work context, right? Like I can't interview anyone at CHEO, obviously, that'd be a conflict, but just generally, like you're all in healthcare. So that can be hard. It is hard to be out there, and I used to worry about it more. I haven't had any bad things, but I would say the most important thing is having some system that backs you. So while I was in the program, that was great because there were these very senior people who had like been the editor of the Globe and Mail, who was now teaching the program. So they would be like, you're fine, this is how we deal with it. When I wrote, there was actually somebody at CHIO who was unhappy with the story that I wrote at one point, mainly because I had not included them in their work because I couldn't, because it would have been a conflict, which I had explained, but they were not happy about that. And that was a good experience. I mean, an educational experience that helped me figure out how to do things a bit differently in the future. But it was good because I had a CHIO comms director to go to, and she's essentially kind of an authority in that space, and to say, hey, here's what happened. Help me understand. Should I have done something differently? Should I have done it? And that person kind of backed me and then explained and took care of it at the organizational level. So I'd say you don't want to be doing things completely on your own, right? Especially if you're new to it and you think that there might be some.
Thank you so much for a wonderful.
You're welcome. I'm happy to talk to anyone. If anybody wants to write something, good luck with call, please. Here's a group, there's a publication called The Conversation that is meant for people who are students and professors to write, and it gets published. It's through Toronto. And basically they will help you write it, or you can partner with somebody else who knows how to write, like me or somebody else. It doesn't have to be me. And they are a platform that you can do things through that's kind of vetted through a health lens, because the editor of that is a physician actually. And so if you're interested in dabbling or want to write something about your research or a topic, look at The Conversation online. You can write all kinds of articles like essay type, news type, whatever. And it's a pretty low risk way of doing it. They'll help you with it. You don't have to deal with the big outlets, all of that. But it's a neat way to kind of get into it, get your foot into it.
Thank you.
Okay, you're welcome.
Thank you so much.
Thank you.
Sorry for the difficulties.
Very nice.
Did you hear us? Didn't ask about the word.